Okay. Today we're gonna answer a few questions, doubts from our students, um, from Dr. Das and Dr. Siba. Okay. So first we want to answer some questions from Dr. Das. Okay. Let's just go to the slides. Wait a second. Okay. Okay. So this is the question from Dr. Das. Okay. So here it says, once the patient come in your office, what will you do for AMCT screening protocol? Uh, and then if both legs are even, then what will we do? What step we should do? Okay. So if the patient comes in your office, first thing you should do is doing a palpation, a screening test in a weight bearing position. And we'll discuss about the Palmer techniques evaluation because all these techniques that we are teaching in this course is based on the Palmer. Okay. So we call that straight chiropractic or full spine chiropractic. We have to see the body as a whole, like we discussed in the DOMP course. It's the same. So we're not gonna follow the symptoms, and we're treating the body as a whole. Okay. So when the patient comes in your office, you will have to see the body as a whole first, and in a sitting position or standing position. I usually see the patient in a sitting position. Okay. We'll discuss about these palpation and do a review about the screening test. Okay. So before the patient will be in a prone position, we will, for AMCT, we actually see the patient in a prone position, the leg band test. But before doing that, we always see the patient in a sitting position. Okay. Even if we are going to do Gonstead, AMCT, or Thompson techniques, or any kind of techniques, we'll have to see the patient in a sitting position and find the major subluxations. Okay. And then we have the patient in a sitting position, I be in a prone position, as in AMCT. And let's say the patient has both even legs, okay, in extension, position one, okay. Then we bring it to position two and see if both legs are even in position two as well. In that case, um, there's no findings of any subluxation left that you could do in AMCT. Okay, so you have to compare in the sitting screening test or palpation test in sitting, and in you have to check if those findings that you seeing in sitting position and prone position are the same. Okay. And if you find some subluxation in sitting position, but in prone position, both legs are even in extension and flexion, there are a gap between those two evaluations. In that case, you won't proceed, you should not proceed with AMCT. Or maybe you're not doing the leg length test properly. Okay. So in that case, um, if I was you, I would not go to the AMCT screening protocol. I would go to the Thompson Deerfield test, and maybe the cervical syndrome is masking the subluxations at the pelvic. Okay. So, or maybe you've done all the things previously in your sessions when they came in before, and all those subluxation that you can find in AMCT are cured. The things that are left is deflection and extension. So you will have to see position 3. Okay. So we'll discuss about position 3 later on in the course. So if I was you, I will switch to Thompson screening test. Okay. If in this case, okay. And number 3, then if isolation test of L5, now both legs are even in L4 and 2, and what we do is go on to the upper regions, the thoracic, okay, for the basic protocol. So if L5 4 2 was even, we go on to the upper regions. And you have to remember that in AMCT, before going to the pelvic, you should see the medial knee and the lateral knee. Okay, INEX. Okay. So after correcting the um, knees, maybe the legs will not be even because maybe the knees or the feet was masking those subluxations in AMCT protocols. Okay. So I think we discussed about the knee, the medial and lateral knee. So you should recheck those kind of issues. Or maybe the patient has something with the pubic, okay, the pubic problems, or the coccyx. Okay. Okay. So in AMCT, there are techniques for the pubic and also for the coccyx as well. Okay. The adjustment part is similar to the Palmer techniques or the Gonstead or Thompson techniques or AMCT. There are they are all the same. Okay, the line of drive are the same. Okay, maybe the contact point is a little bit different for AMCT, but for Thompson, Gonstead, Palmer, they are the same. Okay. Number 4, then if the patient can't bring his head back or in front, can't bring his hand back. Oh, I see. If the patient can do the isolation test for these, like L5, bring the hand, PD, hand behind the back or something like that. If they have a frozen shoulder, we should do a stress test or pressure test instead of doing any um, isolation test. Okay, that is the same as in Thompson techniques, right? So we could do a pressure test and stress test to reevaluate. Okay, but before that, we should do a screening test by palpating in a sitting position, right? Okay. Number 5, if the patient is having chronic osteoarthritis, knee can and he can't bend the knee, what we do, that's the same answer. We do a stress test or a pressure test and palpation as well. Okay. Number 6, patient can't lie in prone position. Then what will we do? We can't do the AMCT, so we do the other techniques. So if the patient cannot lie down in a prone position, AMCT protocol is not useful. So we can use the activator, the instrument as an adjuster, but the palpation part, the evaluation will be done by static palpation, motion palpation, or X-rays. Okay, and you could use the activator as instead of doing manual thrust. Okay? Number 7, after 21 days, if you get no PD leg, both are even in position 1 and 2, what will you do? But still the symptoms are there. Okay. So actually, in from 1 to 6 sessions, all the symptoms should be better. Not all the way good, but it must be better. And if there's those symptoms are getting worse, maybe the patient is not doing what he's supposed to do. Something he's doing what giving stress each each time you treat them after treating, like overstressing themselves by sitting in a bad posture, or maybe this training. Like Dr. Summit said, the training is not good. They're overtraining themselves in a bad manner. Okay. Or some kind of immune system, uh, some what chemical problems. So many patients, after you treat the patient and you think all the major subluxations are gone, but the patient still suffers from pain or some kind of symptoms, it's most of the time it's something that the patient is not supposed to be doing. They're not their daily habits are not fixed. Okay, or maybe you're not done with the dura, especially the coccyx and the sphenoid bone in AMCT. Okay, so in Thompson as well. When you do Thompson techniques and all the subluxation of the spine are gone, you always go to the coccyx and the sphenoid. Okay, so that is the coccyx is the most the first or the last, the end of the dura connects all the way up to the sphenoid. If there's any subluxation at the coccyx, you will have to treat that. Okay, and that is the most primary subluxation. Okay, so coccyx we usually treat it with the activator or Gonstead or Thompson techniques. Okay, and it is very useful. Okay? Most of the patient that has severe symptoms, you should see the coccyx. Okay, okay, so that I think I covered everything that Dr. Chitrandon said. Okay. Is there anything else to add?
No, sir. Thank you, sir.
Okay, that's good. So we'll clear all these coccyx and pubic and all these no the position 3 later on. Okay, and the palpation part. Okay. Okay, so let's go to the questions from Dr. Siva. Okay, just a minute. Okay, so Dr. Siva sent me uh, X-ray, and I'll show you the X-ray later on. Okay, so L5 rotation and side bending in AI sacral base. Okay, in Thompson technique, and if the rotation occurs in Thompson and there's no tender points for Deerfield negative for the sacral AI, we always go to L5. That is on the textbook. Okay. And AI correction in side posture. You want to know the AI correction in side posture and the contact point line of drive. in a side posture. Okay, we'll do that. And L5 side posture adjustment as well, or the evaluation. This goes on to the next question. So, Gonstead pelvic prone examination, finding fixated side SI joint dysfunction based on lumbar body rotation, tenderness, and edema, motion palpation, or spring test. Okay, let's do that later on. Okay, and static and motion palpation of pelvic along with L5 and determine for adjustment using sacral base, ILA, and L5 rotation. Okay, we'll do that. Okay, and you see me palpating the sacral base, ILA, L5, and the TP, and decide what technique you use to adjust. Okay, let's discuss that. Okay. Okay, so those are the main questions for the pelvic and L5 complex. Okay. And also the AI sacral base adjustment in the side posture. Okay, so these are very good questions. I think a lot of you are have the same kind of doubts. So let's talk about that today. Okay. Okay. So where did I go? Okay. No. Let's go to the slides first. I'm the X-ray. Just a minute. Okay. So this is the X-ray that Dr. Sieber sent me. So this is from P to A. So left is left and right is right. Okay. So Dr. Sieber flipped it around for me so I could tell. So first, I taught everybody to see the lateral view for the lumbars or the subluxations of the spine. So from down to up, we have to see. Okay. So this lateral view here, this is the sacral base, and this is the inferior portion of L5. You can see that L5 is posterior than the sacral base. Okay. Okay. So this is posterior against sacral base, L5P. Now we go up to L4. Okay. And L4 is P against L5. So L4 is P as well. Now you go up here. Okay. L3 is P as well. And go further up. L2 is P2. Okay. L1 is P. Okay. And T12 is a little bit P. Okay. So what you should see in the lumbar region, we're going to fix the lumbar region before going to the thoracic, remember? So between 5, 4, 3, 2, 1, which one is the most extended? Okay. And the inner disc space is the most narrow bone will be L5. Okay. So this is the most extended. L5 is more extended than L4. So you usually adjust from L5 or 4 or the sacral base. Okay. So though these are the major subluxations we have to treat before going up, because I told you that the sacral base should be parallel to each other. Okay. Before going to the upper components. Okay. So that is due to the sacral base or the SI joints or L5 or L4 complex. Okay. So the pelvic includes L5 and L4 because the ligament attachments will be for L4 and L5 and the pelvic as well. Okay. Okay, so L5, we should adjust L5 in this picture. Okay, this is a major subluxation. Okay, after treating L5, we should reevaluate L4. If most of the time, if we adjust L5 in a full spine technique manner, L4 will be and the upper components may be compensations of L5, so we don't have to adjust L4. Okay. So you will have to do a palpation, pre-evaluation, and a post-evaluation for L5 and both L4 as well. Okay. So after treating L5 and L4 is still posterior, we could do an adjustment for L4. Okay. If we treat L5 and the posteriority of L4 disappears, we don't go to L4. We leave it alone and go to the next. Okay. And L5. So there's no issue with the sacrum, okay? Because this is anterior. Sacral base is anterior to L5. Okay, it's the same joint here. So we should pick which one you should adjust in this picture. Okay. So L5, this is P to A. So you can see that the sacral base is tilting to the left. So if the patient has a left short leg, we should, in Thompson, we will adjust the sacral AI. Okay. But let's go back to L5 in a Gonstead manner. Okay. Let's leave the Thompson alone right now. Okay. So the sacral base is tilting to the left and the femur head is lower on the left side. So the patient should have a left short leg. Okay. If the pelvic was the issue, we should adjust the pelvic, okay, the SI joint. Okay. So after treating the SI joint and the tilt is remaining, we should adjust L5. Okay. So in Deerfield, um, Deerfield, it will be a different concept that I'm talking about because I'm talking about the Gonstead. Okay. So first, let's talk about the Gonstead. Okay. So if it is Gonstead, we will check the most posterior. So posterior after treating the SI joint, or if the SI joint is not positive, we should adjust L5. Okay. So L5, there's a side bend to the right. Okay. Because this is the transverse process. The inner space between the inferior angle of the transverse process and the this sacral base, the left side is longer or wider than the right. Okay. So here, this transverse process of L5 on the right side, and this is sacral base. This is very closed on the right side, and left is opened. Okay. So there's an open wedge on the left side. Okay. So it's side bend to the right. Now you could, for the spinous process rotation, deviation of the L5 is deviating to the right against L5. Okay. So it is PRI. If you can visualize this spinous process, we could see the width of the articulation, superior articulation here. So here, left articulation, articular pillar is wider than the right. So the wider side is posterior and the narrow side is anterior. Okay. Or you cannot actually visualize in this picture, but the facet joint between the superior articular process of the sacral base and the inferior articular process of the L5, you could see a little shadow here. It's in a a little bit in a sagittal plane. So you can see a shadow here between the left side, but there's no shadow here on the right side. That means that the left is opened, okay, in a sagittal plane. That means that the spinous process is rotating to the right side, okay? You know what I mean? So this open space is the opposite side of the deviation of the spinous process. That means that the open side will be the body rotated side, okay? Because the articular process of L5 is rotating toward the right, okay? Because the spinous process is rotating to the right. The right side will be closed and the left side will be open. So to determine the rotation of L5, we could visualize this space between the facet joints, okay? For the upper components, it's not in a sagittal plane, so we actually see these center of the spinous process, okay, and compare to the one below, okay? Or the visualize this circle, which one is wider. For L4, the right side is wider than left. So L4 is rotate, spinous process is rotating to the left. It's PL. Okay. It's side bending to the right as well. So it will be L4 will be PLS. Okay. L5 will be PRI. Okay. So the side bend, you could see this shadow here, the transverse process in the body here and here. You place a dot here on both sides and draw a line. Okay. And compare with L5. Okay. L5. L5 transverse process line is here. And so the open wedge between L4 and 5 is on the left side. Okay. So, and the spinous process is rotated to the left. So it is PLS. It looks as though it is PR in a straight line, but you can see that the superior angle of the spinous process here and here, it's slightly deviating to the left, okay? And the right side of the articulation, you can see the whole circle, but the left side is the edge is not visualized because it's rotating anterior, okay? So it is L4 is PLS, L5 is PRI. Okay. Okay. So if it was Thompson technique, it'll be totally different because you can see that the um, spinous process of L5 is rotating to the right uh, against sacral base, but still you can see that the sacral base is side bending to the left, and actually the rotation is occurring anteriorly. Okay, so it is AI sacral base on the left side. So if the patient is in prone position, you will see that the left leg is shorter. If the right leg is shorter, maybe there's some, it's due to the scoliosis of the spine. Okay, maybe the scoliosis is making it the right short. Okay, or the compensation of the psoas on the right side. Okay, the psoas is compensating, is masking these problems, or maybe the erector spinae on the right side. Okay, so you should release the psoas or the muscle tightness on the right side before doing the any Deerfield examinations. Okay, that is written on Thompson book. Okay, so you should go through that as well. And in this case, the sacral apex is deviating to the right, but you can see that the coccyx is deviating to the left. So I think this patient has a severe subluxation at the coccyx. Okay. So going through all the spine and the symptoms is not cured. You should go to the coccyx, and right after treating coccyx, you will have to treat the sphenoid as well. Okay. That is the Thompson rule. Okay. So Dr. Clay Thompson said that most of the severe neurological problem is from the coccyx and the sphenoid. So you're not finished until you treat the sphenoid in any cases. Okay. Okay. So that is all for this. Okay. Okay. Dr. Siva, did I explain it right? Is that what you wanted to ask?
Yes, sir.
Okay, so let's do the evaluation part and the treatment part. Okay, let's start from the what, AMCT that Dr. Das said. Okay, so for the sacral base, okay, there's sacral base like this and like this. Okay, and if it extends, it's the sacral base posterior portion is what, inferior. Okay, and if it is anteriorly flexed, okay, it will be like apex P. The posterior aspect of the sacrum base will be superior. So AMCT for apex P, we call it superior. I mean, yeah, superior sacral base. Okay, and if it is base P, we call it inferior sacral base. Okay, so just to remind you, let's go to the slides again. Okay. So this is the notes that we studied in the first module. Okay. So this is the test for this is position 3. Okay. So the both knees are beyond 90 degrees. Okay. So in that case, we could see if in position 1, okay, let's say the right leg is short, okay, and we bring it into position 3, we can see that if the short leg remains short or it gets longer. If it gets longer, lengthening of pelvic the PD leg in position 3 indicates superior sacral base. Okay, and shortening, short to short, in position 3 indicates inferior sacrum. Okay, so that means if it is flexed, it means it is anterior. It is apex P. Okay, so if short to long means it is apex P. If it is short to short, it means it is extended. Okay, so that means it is base P. Okay, so for no, this writing is wrong. Okay, so this is wrong. I made it right wrong. Okay, so if it is short to long, I said it is apex P. So we're gonna contact S3 or 4, and the line of drive will in the center of spinous process of the sacrum. 3, it should be S4. Okay, so line of drive is correcting the apex P, so it will be inferior and anterior. If it is short to short, we're going to contact on S1, and the line of drive will be treating the base P. So it will be anterior and superior. Okay. So we call this inferior sacral base for inferior. That's why the line drive will be superior. Okay, inferior. That is a base B. Okay, if it is superior, it will be apex B. So the line drive will be inferiorly. Okay. Okay. So in AMCT, there's lateral sacral base that is the same as in AI sacral base, or the torsion of the sacrum we discussed in Thompson techniques. Okay. So we could do a stress test or pressure test, and the leg extension test that we did for in Thompson techniques. So the evaluation is actually the same as in Thompson. So the adjustment will be um, on the S1 or 2. Okay. So we adjust the superior aspect, the lateral to medial, and the inferior aspect towards the opposite direction. So S1 on PD side, line and drive will be lateral to medial. Okay. And a little bit superiorly. And we're going to contact on S3 towards the opposite direction. Okay. Okay. So that will be medial to the opposite direction and a little bit inferiorly. It's like doing a torque, okay, like we did in Thompson. Okay. The contact point is in the center, but on the Thompson technique, it is always on the contralateral side of the AI sacral base. Okay. So the contact point is different, but the adjustment part is actually the same. Okay. Okay, so for the coccyx, there's a isolation test by asking the patient to squeeze their buttocks together. Okay? And within 3 seconds, we'll see if the leg gets short. If it gets short, there's a problem at the coccyx. Okay. If it is short to long, the base is deviating towards the PD. Okay. If it is short to short, the base deviating towards the OPD side. Okay. So major subluxation is actually posterior inferior coccyx base. Okay. So direction will be exactly the same as in Gonstead or Thompson that we did in the first module. I demonstrated in Delhi. Okay. So it will be exactly the same. Okay. And for the laterality, the deviation part, we always do not contact on the bone. We always contact on the sacral uh, coccygeal ligaments. Okay, on the translated side. Okay, so the deviated side, not on the transverse process, on the ligament. And the line of drive will be superior and lateral and posterior. Okay, that will because the coccygeal ligament is pulling the transverse process laterally. We could correct the ligament instead of the bone to loosen the tightness of the coccygeal ligaments. So in this case, we do not contact on the bone. We contact on the ligament only. So to release the tightness of the ligaments. If we release in this picture, it's a right laterality. Okay. So the transverse process is deviating to the right, and there will be an open wedge on the right side, okay, between the sacral apex and the base of the coccyx. So usually you should, in manual thrust, we contact on the right transverse process and adjust it superiorly and posterior superiorly and medially using a torque when we did the Gonstead. But for For the activator, um, the tip of the activator is too sensitive, so it is too hard and it is very painful. But we should contact ligament instead. So the right ligament will be tight. It will be pulling the transverse process on the right side laterally and inferiorly. So if we loosen that, the transfer process of the coccyx will go medially and superiorly and anteriorly. Okay, so that is. But after doing the adjustment, we should always go to the sphenoid that is not in the AMCT. It's in the Thompson techniques, okay, or the DOMP part. Okay. Okay, so let's just show you a sample. Okay. So, so, so first thing we should do is when the patient comes in, we should have the patient in a sitting position to find the major subluxation. Okay. That's what the group. What you make it. What you make it.
Good afternoon, ma'am.
Hmm.
Hello, ma'am.
So we're gonna have the patient in a sitting position. So we have to see the full spine. And remember these three fingers. These fingers should be closed, always closed, okay? And the tip of the three fingers always has to be in a straight line. It's not like this. It's always in a straight line. So we could, for the cervical, we could flex and see the center of the spinous process. From C2 to C6, it divides into two spinous process. Okay, from C7, it's only one, like the thoracic. So we're gonna see the space between these divided part. Okay, so these fingers will be closed and in a straight line. We could see which is most posterior. First, we want to see the posteriority. Okay, because C2 is always posterior. Okay, and the most posterior prominent spine below that will be C7, not D1. Okay. 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 Now from T1, you could go down to the thoracic like this and see which spine is most prominent. Okay. Okay. From T1 to about T5. Okay. Go down. And from 5 to 10 and the lower thoracic. We could bend her a little bit and see the posteriority of the lumbar, L5. And you go all the way down to S1, 2, 3, 4, and the coccyx. Okay? You have to go all the way down to the coccyx and see if it is firm. Okay? I'm touching the center, the spinous process, so I can see that her coccyx, her sacrum is in a little curvature like this. Okay? So she has a right open wedge between the sacral base. So now I know that she has a right short leg, okay? Because the sacral base is side bend into the right. As I can see, the scoliosis here on the lumbar is slightly to the right. Okay, it's called the curvature. The convex is on the right, and there's an open wedge between the sacral base. That means that the sacral base is tilting to the right because S1 and S5, I can see that it's deviating like curvature. So in that ways, the sacral is side bending to the right. And I could see the height of her shoulders. Left is inferior, right is superior. And I can also find the iliac crest here with my finger and palpate L T12, or I could palpate the medial aspect of the rib, floating rib. Okay, so I can see the space between the iliac crest and what R12. Okay, I could lift with my thumb on the lift R12. Now I could also have her to bend forward, meaning kakande. Okay, I'll hold and see that the right side is more superior than left. So I could stabilize the iliac crest with my index finger, and I could see that the R12 is more superior on the right. So that means that she has a curvature on the right side. Okay. Pelvic and T12, right is going like this. Okay. So that means she's in this manner. Okay. Okay. Now I could see the rotation in the same manner. Okay. So let's just go for the lumbar. This was the spinous process. Okay. Now I could see the center of the process. Somebody please turn your mics off. Okay. I could see the center. You can see that my thumb and pinky is extended. Okay. And this contact is very soft. Okay. It's like touching your eye like this. Okay. If it is hard, you can't feel anything. It's soft. Okay. And fast. Okay. So I can see that she has a little dent here. And here below that, then I feel some posturality on L4 and L5. Okay. Then L4 and 5. So my finger stops here. So L5, my middle finger is here. I'm L4, spinous process here. And above that, don't widen your fingers. It's always narrow. Okay. I could see the space above and below with my index above and my ring finger below. I could ask her to bend forward or manukunate. Okay, hold. And see that there's space between L4 here and 3. This is L4, and below that, there's no space here. Okay, I could go down and find L5 with my middle finger and see the space here. L4 and 5, there's no space. L5 and sacral base, there's no space either. So she has two subluxation, L4 and 5. And I could see the laterality. Okay, so I'm going to go lateral to the spinous process and see that slide my finger down from the right side. It's a scoliosis like this on the right. I could see from the left side as well. So I can feel a little bump and on L4 to the right. Okay. And L5 goes to the left again. So L4 is PR because L4 spinous process is deviating to the right between 3 and 5. So this is a 3 fingers. This is L4. This is L5 and this is L3. So this one spinous process deviated to the right. So it's L5. L4 is PR. Okay. Now I could glide my fingers on the mammillary process and compare as well. I can feel a little pebble-like stone here at the mammillary process of L4 on the left side. But on the right side, I feel more prominent on L5. So L4 is like this, PR, and L5 is PL. Okay. So that's how you determine. Okay. So you go all the way down from L5 and you could find the sacral base. It will be stuck here, okay? On the lateral aspect as well. So it's very easy to find L5. It's totally, L5 is totally different from L4, totally different from the sacral base. So you can find L5 very easily, okay? Just lining your finger. If it's fast, if you go slow, you won't find. If you poke or going like this, you can't find anything. You slide, and I can find it in 1 second, okay? Even if it's muscular or fat, I can find it in 1 second, okay? So you should get used to this. So this is a drill that Palmer students does every day, okay, on their hands. You can feel the vein, okay? So close your eyes and feel the bit vein if you go fast. If you go slow, you can't feel anything. It's in a straight line. So she has a curvature like this, okay? Now I can find the PSIS like this as well, okay? I can go laterally, medial laterally, and go down. I can find the spinous process and compare with the right and left, okay? So I can see that with my middle finger, the spinous process is more prominent than the left. Okay, it's more prominent, so she might have a PI, and it is lower. Right side is lower than the left, so she has a PI on the left side. It's prominent, or maybe the left side is AS. Okay, now you could, like I said, L5 is PL by doing the static palpation. PL, that means that the right side, if the right side was positive, she has a short leg on the right side because the sacrum is side bending to the right. Okay. That means that L5PL is, and the PSIS on the right side is more prominent and inferior. That means she has a gear field positive on the right side. Okay. Do you follow? If L5 spinous process was rotated to the right, it might be a Deerfield negative on the right side. Understand? So you have to put all these things that we learned in Gonstead and Thompson and AMCT together in your head. Okay. So maybe AMCT and Gonstead is a little bit different, but Thompson and Gonstead is actually the same because it's based on Palmer techniques. Okay. Okay. So I have to check that in a prone position as well. But if the prone position and sitting position was different, according to Palmer, he said that sitting is the most accurate. If the patient is in a prone position, the muscles that was contracting will compensate, relax. And you won't see the major subluxation in a prone position. Okay. So you will have to always do the reflex test in a prone position. If you want to see the bony structure as is subluxated, you should see it in a weight bearing position. Okay. So if it differs, the sitting position is the most prominent. I mean, the accurate subluxation. Okay. And in prone position, it might be hiding it because the muscles are relaxed. Okay. Okay. Utsubusen natin. Let's just do a quick scan for these problems. Okay, so AMCT, okay, right short, okay, just loosen it to reset it, right short. Now we should go to the knee. There's no medial knee, there's no lateral knee, so we could leave the knees alone. Okay, after that, we should go to the PD side, PI. So it is positive. She has a right PI. Okay. So I did a pressure test for PI. I can I should also do a stress test. Okay, just to reconfirm. Stress test, it gets the right gets shorter, and pressure test it gets longer. So that was the same finding that I saw in sitting position. So I could do the adjustment part. Okay, one each. Okay. Reevaluate, the right gets long, so I could reset it. Okay. And it got short again. Okay. So I could do the opposite left OPD side AS. So it remains short. Stress test, pressure test, it doesn't change. So she doesn't have anything at the pelvic on the left side. I could palpate in this manner again. Okay. PSIS. Okay. And L5 spinous process. So I'm palpating with my fingertips. Don't use your finger pads, okay? For palpation, always use your fingertips like this or like this, okay? I can find the sacral base here. Above that, I can find L5 spinous process is deviating to the left. Okay, so she has PL. Okay, and I could use my middle finger to poke lateral to L5 spinous process gently without stimulating muscle. I could go deep in anteriorly and superiorly. Okay, I could feel that the right side is moving more superiorly. The mammillary process on the right side, there's more laxity on the right side. Left side remains. It's stuck here. So it's side bending to the left. Okay. And the spinous process rotating to the left. Okay. So it's a PLI. Okay. PLI. Okay. So that is a finding that because she has a PI on the right side in Gonstead or Thompson, I could adjust PI. You know, if I was to use the what Thompson, I will just do it in this manner. Okay. And after that, we could go to say L5 and determine if this adjustment was effective. Okay. L5 will rotate as well. Okay. Okay. Now I could find L5 and it's fixed already. So I don't have to adjust L5 anymore because when I adjusted the right PI, the ligament brought L5 towards the right. I could go to L4, but I have to evaluate it again. But if it's in AMCT, I could do a isolation test for L5 till okay, L5 isolation test. It's long. Okay, it's still long, so it is negative. L4, left hand behind him. It gets a little bit short, so I should do something for L4. Okay. So I should palpate before going to the what isolation test. Oh, okay, because I palpated that it was PR. Okay, so I'm gonna find L4 and find the mammary process and see that the left side goes more superiorly. Okay, right side is inferior. Okay, it is PR spinous process is deviated to the right. Okay, but still, I could just do the isolation test. Okay, position 1, 左手腰の後ろ置いて right short, position 2, right gets longer. So it's a finding that it's a PL. So my palpation and this AMC test was different. Okay, but in sitting position, I saw it was like I said, it was PR. Okay, So maybe this isolation test wasn't accurate. So I should do, just to check, I should do a pressure test or stress test. Okay. I, so if it was like I did this isolation test, it was PL, but I thought it was PR. I could just bring the spine process from left to right, okay, and see if it gets longer, but it gets shorter. Okay. So I think I was right. So I bring the spinous process from right to left, as I thought it was, and do the stress test, pressure test. Now, right gets longer. So the direction was not accurate when I did the isolation test. My palpation was specific. I do a adjustment once and recheck. Right gets very long and the leg is very loose now. Okay. Or I could do the prone adjustment. Okay. Okay. So it was like this. So prone adjustment, I should go from the left side, right side, because it's PR. Find spine process. Always do this, okay? Do this. Place your middle finger, contact with the pisiform with a high arch. It's the spinous process deviating to the right, so I'm going to pull it towards medially to the center. Okay. With a high arch, I could do a thrust. Okay. I'll go recoil. Okay. Now the right leg is very long now. Okay. So we go up like that. Okay. So I adjusted everything. Let's say I adjusted everything, and the next visit, when she comes in, both legs are even now. Okay. Okay. And I'll bring it to position 2. It's even now. Okay. So in that ways, I don't have to do anything for her. Okay. Actually. But maybe the psoas or everything is masking, or maybe her coccyx has a problem, or sacral base is in flexion or extension. So I'm going to flex the knee joint over 90 degrees. Okay. And we check. The leg is right, gets a little bit shorter. That means she has something remaining. Okay. That is a flexion or extension dysfunction. Okay. Now, I'm going to ask her to, I'm going to bring her, the right is the original short leg, PD leg. So I'm going to bring her knee joint over 90 degrees and see the height. So I can see that the right short leg gets shorter, okay, short to short, okay. That is a sign of base P, okay. If it's short to long, it is apex P. I could find the sacral base S1 and do a pressure test. Okay. So I'm gonna find S1 and slightly push it anteriorly. Okay. It remains long, even longer. Now I'm going to S3 and push it inferior, pull it inferior and anterior to bring it more base P. Okay. So right gets very short. Okay. Now the direction of adjustment with the activator, I could contact on S1 spinous process. Okay. And direction will be anterior superior. Okay. Because it's inferior sacral base. Okay. So right gets longer. If it was if it gets short to long, I will find S1, 2, 3. okay, and pull the tissue slack down in contact, hooking my finger like this, and direction will be anterior and inferior to bring the apex A. It's apex P, so I want to bring it like this, okay? Okay, that's all. For the coccyx, I could ask the patient to お尻をぐっと締めて、お尻のぐっと、okay, relax and relax. And right gets short, okay? Now, bringing it position 2, I can see that the left side is longer in position 2. That means it's the coccyx is in like this, okay? The base is A and the apex is P, okay? And the transverse process is deviating to the left, okay? So I could do a pressure test, a stress test by bringing the skin down on the center. Okay, right gets very short. Now I could do a pressure test. Okay, I'm going to pull this tissue stack up very gently. It gets long, so it was deviating to the right, left. Okay, so I could pull I could do a torque like this to deviate to counterclockwise. It will give us stress. Okay, right gets short. Now I'm going to bring it into clockwise. Right gets very long, so the contact point will be on the left side ligament. So I'm going to find the transverse process of the coccyx, and the direction will be I to S and laterally and a little bit posteriorly. See? And that is for the laterality or of the transverse process of the coccyx. So the right is long now, but I should also do a stress test again for the posturality of the apex. So I could do a adjustment. Okay. So I'm gonna pull this skin up and contact on my thumb. Okay, and the direction will be superior, slightly anterior. Okay. For the Gonstead part, or the if it's a Thompson technique, I should lift the pelvic piece up. Okay. So this pelvic piece does not go up. So ちょっとこれ入れて骨盤に。So that her apex will be the most prominent. Okay. So she will be in a hyperlordosis, so that her apex will be sticking out posteriorly. So it will be easier to adjust. I'm going to pull the tissue slack up, and then I'm going to use my PCC form on my thumbnail. Okay, and direction of adjustment is superior. Okay. If it was Gonstead, I would just do it like this. Okay, thrust. Okay. That will be all. Okay. はい、これ外そうか。Now, for the if she has AI sacral base, okay, on the right side, if she has, I will have the left side up. じゃあ、一回こっち座って、左向いて座って。そのまま横向け。And in a side posture with the AI side down. Okay. The setup is just like we did for the lumbar or the pelvic. And feel the space between L5 and sacral base. Feel the tension. Push the knee towards the apex, posterior apex on the left side. so it will be more prominent, so I could contact better. Stabilize and pull the shoulders towards the right shoulder towards the apex here. So side bending, and do the traction, the top shoulder away from the apex, and slightly posteriorly. And as I contact on the apex on the so the if she has a AI sacral base on the right side, it will be side bending to the right, and this will be anterior. So the most prominent will be here, right? So I will contact here with my Pisciform, okay? And my middle finger will be facing the right facet joint on the right L5 sacral base. So in this left oblique axis, it will be rotated like this. So this will be the most prominent place. So I will contact with my soft Pisciform. And my middle finger will be in this axis, in the right oblique axis. Okay. So I could feel the sacral base on the right side pushing posterior as I do a torque this way, counterclockwise. Okay. And my left leg should be right in front of her sacral base. Okay. So I could drop like this. Okay. Yeah, she doesn't have an AI, but if I was to do the thrust, I'd be doing thrust. Anteriorly on the left apex as I do a small torque CCW. Okay, like this. Okay. I could do this on a drop table like Thompson did. Clay Thompson used a drop table in the side posture as well. So the adjustment will be using it in the drop table. Okay. That will be for AI sacral base. Okay. Okay. So for the other adjustments, we could do it another time. Okay. So I have another class after this. So for today, this will be all. And if you want to see something else, just write it on WhatsApp. Write me a message so I could discuss it in this next online. Okay. So these questions are very good because it's not between you and me; it's between all of us. So everybody could I could explain to everybody because these questions are very good. Okay. Thank you for providing these doubts, Dr. Das and Dr. Siva. Okay.
Thank you, sir.
Okay. Any questions? That's good. Did I explain everything?
Yeah. Yes, sir.
Okay. So in the next practical, we'll do these techniques. So you will all be familiar with. Okay. Okay. Thank you. Let me.
Thank you, sir.